Welcome to your narrated podcast on outcome writing and analysis, management planning, and conclusion of care. This will be a continuation of your lecture from the fall semester with an adult spin on some of the concepts that were previously presented to you. In taking a look at these learning objectives for this lecture, you will see some similarities with the content that was presented last semester. Part of this lecture will focus on writing outcomes. So that information should be familiar to you. We'll talk about how to establish outcomes that are measurable and objective, outcomes that you can reproduce, and that focus on function for the adult patient with a neuromuscular disorder. And also with outcomes, something new that will be introduced is a standardized person-centered outcome measure that focuses on individual goal selection and scaling of those goals for those patients with neuromuscular disorders. We'll review those terms that we discussed in our last lecture in the fall semester related to the differences between discharge, discontinuation, and conclusion of care. We'll talk about episodes of care and what might interrupt an episode of care for an adult patient with neuromuscular challenges. We will talk about the process and the documentation that's needed as it links to outcome analysis and then getting a patient ready to be concluded from therapy. And we'll also apply those terms in the constructs of research evidence for patient care. In a week or so, you'll be meeting your patient for clinical exposure and beginning your examination with that patient. You'll take your history, your observation of function, your review of systems, your specific tests and measures. You'll choose a standardized outcome measure, and from all of that information and data, you'll synthesize and form a picture of this patient and then move on to establish appropriate and functional outcomes for your patient. Once again, you'll be getting experience establishing long-term outcomes, short-term outcomes, and session outcomes, similar to what you did last semester, but obviously with an adult focus. If we think about starting with the end in mind, the long-term outcome, we know that that is an outcome that is going to be reproducible over time and therefore measure learning, as are the 2 or 3 short-term outcomes that you end up establishing. So again, these are measurable and functional, and will target the reproducibility of that functional pattern, which is really more of that learning. Our session outcomes are areas, functional activities that we want to have happen with that patient within that one particular session that you've developed intervention strategies for. And that outcome is going to measure more performance because we're not looking to test that specific outcome over multiple treatment sessions. So really at the performance level where you would end that outcome with the number of trials, but keep it on that particular session. So let's break down the differences and do some compare and contrast between long-term, short-term, and session outcomes. As I said previously, the long-term outcome is really what is the best case scenario or the end game for that patient. So obviously this is based on all of the data you've gathered, your clinical expertise, and also what the patient wants to be able to accomplish with that episode of care. So what is their focus? What do they want to be able to do that they can't do or improve upon? Again, this is going to be measurable, objective, it's going to link to function, and it's going to measure learning. So if you recall back on the definition of learning, thinking about being able to reproduce that behavior over time, potentially across different settings as well. That's really the definition of learning. And typically our long-term outcomes are going to focus either at the participation level, so that individual's role in society, or the activity level, that individual on a specific task of the ICF. Typically, we're only looking to develop one, maybe two long-term outcomes for either our pediatric or adult patients with neuromuscular disorders, because from each long-term outcome will span several short-term outcomes that will link directly to that long-term outcome. So just to review how that short-term outcome is constructed, very similar to the long-term outcome in that it has to be measurable and reproducible and linked to function. We're also going to look to measure that short-term outcome over time because we're looking to measure learning. So thinking about number of consecutive treatment sessions or a certain number of times over a week or two, depending on the service delivery model that you're in. But we're not looking to just make them smaller chunks or benchmarks of the long-term outcome. And this is a concept that we talked about in the fall with the pediatric population. So if you have a goal for ambulation for 150 feet, we're not looking for that short-term outcome to just be a smaller increment of that ambulation goal, so 75 feet or 50 feet. You know, we talked about that really just being a function of practice, in that insurance companies aren't looking to reimburse a skilled physical therapist if the patient can just practice those tasks and skills that they already have, just to be able to do them further or faster or what have you. So the way you establish your short-term outcomes is to ask yourself, what other functional tasks or activities is the patient challenged in, that if they could do those, target those same impairments that impact why they can't currently do their long-term outcomes. So if you're thinking about the patient is challenged with ambulation because they really lack a lot of gluteal strength and they lack plantar flexion strength to be able to push off, then perhaps a sit-to-stand transfer might be something that you select as a short-term outcome, knowing that working through that transfer will also target those same impairments that are a problem for the long-term outcome of walking. So looking to make those be tasks that are separate but certainly linked from an impairment perspective to the long-term outcome. Again, the short-term outcome is going to measure learning over time in the same fashion that the long-term outcome does. And you're looking to make that functional, so that would be either at the activity or participation level of the ICF. And then from those short-term outcomes, you will establish session outcomes. So kind of in the same vein as not benchmarking short-term outcomes as they link to long-term outcomes, you also don't want to benchmark the session goal. So you don't want it to just be an easier version of the short-term outcome, but you want it to be its own individual task that links in some way from an impairment perspective to the short-term outcome, and then probably also to that long-term outcome. Different than long and short-term outcomes, the session outcome is not going to measure learning, but rather it's going to measure performance, or that snapshot in time that's happening over one given therapy session. Usually the session outcome is written at the task level or the activity level of the ICF. And then when you think about establishing session goals for clinical exposure, when you have your patient in front of you, you are going to want to test what that session outcome is in the beginning. So what is that patient's performance on that goal right when they walk in? And the reason for that is that our patients with neuromuscular disorders can really vary from day to day and from week to week. So you want to have a really good, clear picture of what they're capable on that particular day. If it didn't go as you anticipated, that gives you the opportunity to then adjust anything that you need to adjust from an outcome perspective or from an intervention perspective, so that you can have an effective session. And then certainly looking to retest that at the end of your therapy session to be able to document their status on that particular session goal. Next, we'll review how to write and establish the goals, regardless of if we're talking about long-term, short-term, or session outcomes. We're going to talk about establishing goals in 3 different ways or strategies. The first is a review of what we've discussed last semester as it relates to using the acronym of A, B, C, D, and F. Then we'll talk about another acronym as it links to establishing SMART goals. And then thirdly, we will talk about a standardized outcome measure that is used to establish specific goals for patients with neuromuscular disorders. So as you may recall from last semester, we used this strategy of ABCDF primarily when we were talking about outcome writing. So just to quickly review, you know that the audience is the patient that the goal is targeting, the behavior, what are they going to do, or what can you as the therapist observe them doing in this outcome. The condition is really kind of the clarity of the behavior, so how are they going to do it, thinking about are they using equipment or assisted devices, you know, is the ambulation going to occur over an uneven terrain or a hardwood floor, the amount of assistance, the amount of cueing they need, that would all fall under the condition. The degree, that's really the measurement part, so thinking about the number of reps, distance over time, the number of trials, so on and so forth. And then certainly the F, the function. So it should always link to a particular function that is salient for the patient and that you've also determined is appropriate to work towards. The second strategy that we'll discuss to establish and write outcomes is the SMART strategy. So thinking about the acronym for SMART, any outcome you write should be specific in such that it really should be simple with only one behavior in it. So thinking about the behavior as the task or activity that the patient is going to perform, we're really looking to focus just on one. So if you think about the complexity of combining behaviors and then trying to make some judgment as to whether or not the patient completed that, it may be difficult to show progress if they're not meeting all of the behaviors. So for example, if you have an outcome that is written that the patient needs to transfer from a seated to a standing position, walk a certain distance, turn around and come and sit back down, and you break that task apart, there are several different behaviors in that outcome. So it's possible that the patient might be able to do the transfer and the ambulation, but then not able to complete the directionality or the change in direction for that outcome, and therefore wouldn't meet that outcome even though they would have made progress towards it. So you're looking to have really one specific behavior. The next aspect is that you want it to be measurable. So this is the same as what we've talked about in the past. You need to have a way to measure that goal that is reasonable and objective. And you want to think about all components of that measurement. The goal should be attainable or achievable. So you want to make something that both you and the patient want to work on, and it seems feasible that given that period of time that patient would be able to make gains towards that goal. The goal should be realistic. Some sources say that the R should be listed as relevant, but conceptually, those aspects are covered in this acronym anyway, so thinking that you want the goal to be realistic and something that is reasonable for that patient. And then some sort of time-bound component, time-sensitive or time-limited or time-based, so you want to know when this outcome will be achieved by. When thinking of the timeliness of a goal, oftentimes that's predicated based on the service delivery model in which you are treating that patient. And we talked about this in the pediatric lectures. And it certainly applies here with the adult population. An adult who is seen in the acute care service, when you think about establishing long-term, short-term, and session outcomes, those timeframes are going to be significantly shorter than a patient who is receiving rehab services. So you might have a long-term outcome of a week in the acute care services, but that could be 1 to 2 to 3 months on a rehab service. So certainly that timeliness and that to be achieved by will vary based on the service delivery model in which you're practicing. And then just some other areas to touch on that we did talk about last semester, so should be a review, is that your behavior shouldn't be specific treatment strategies. So because those may not link to function. So you don't want to set an outcome that a patient can perform 20 wall squats, even though you know that that's going to improve strength, because they probably don't need to do that for their everyday function. So that would be a good treatment intervention strategy, or standing on a BOSU, or engaging in the WEE. Those are good treatment activities, but we don't want to make those the focus or the behavior of our outcomes because they're not functional. You have a good reason to do those in intervention as it addresses several impairments, but they're not functional for our outcomes. Kind of in that same vein, you don't want to use standardized outcome measure scores as your objective measure in the goal, because again, those aren't typically functional, and we're not looking to improve a certain score on a certain tool. We want to improve that patient's function. Oftentimes those go hand in hand, but we're going to just set the function for what we want rather than trying to improve a score on a standardized outcome measure. When you're thinking about wording of your outcomes, you want to try to stay away from the negatives. So staying away from words such as without or with no. So if you want a patient to ambulate without loss of balance, instead of saying that without, you're going to flip that to the positive and state that they're going to walk independently. So really, again, trying to capitalize on what they are going to be capable of doing. Then when you're thinking about writing the degrees, number of trials, so on and so forth, making sure that your degrees are in line with what is needed for that task and what you intend to address. So and also if it's feasible. So if you think about setting an ambulation goal or a stair climbing goal, and the patient has 5 stairs in their house, and we have a flight of stairs at Damon, and you say that they're going to complete that flight of stairs 4 out of 6 trials. That's a lot of stairs if you think about what is needed for that particular patient's function in their environmental setting. So just making sure that those degrees kind of match what you really intended to get out of that. And then lastly, thinking about when you're picking your behaviors and the conditions under which they're going to be performed, how easy is it going to be for you as a therapist to actually measure those outcomes? Thinking about, percent of heel strike or a certain amount of reciprocal arm swing, those might be challenging to really, observe and gather that data to then be able to report on the goal. Certainly that's not impossible, especially if you're using some sort of video recording, but you just want to be mindful of that when you are establishing the goals, that they shouldn't be so challenging that you're not able to accurately assess them. The last strategy that we'll discuss to establish goals and outcomes for patients is through use of a standardized outcome measure called the Goal Attainment Scale. So there are some similarities with this as it links back to using ABCDF goals or using SMART goals to establish the predicted level of improvement for a patient with neuromuscular dysfunction. through the intervention session. So there are similarities in that respect, but the primary difference is that this is a standardized outcome measure, and we'll talk in a second about the scale that you use, but the scale doesn't change, and you can get calculations that would then make this scale be reproducible and can be used with any patient with neuromuscular dysfunction. So it is a standardized scale that takes into consideration the scoring in a standardized way for that particular patient. So we'll talk about this over the next couple slides, and there is a picture of a sample goal attainment form in a couple slides from now. But in terms of the rating scale, it is a 5-point scale. So it starts at 0 essentially, and then it goes up to in the positive direction or down to in the negative direction. So the 0 score is what you expect the patient to be able to achieve after intervention. So that's the expected achievement level. You set that at a 0. And then when you go to measure the patient's progress, you do your typical measurement, and then you determine whether or not they achieved that goal at a level of a 0, or were they better than their goal? Was that somewhat better? That would be a +1. Was it much more than the expected outcome? That would be +2. Or the converse of that. So was it -1, somewhat less than expected, or -2, much less than expected? Now, you do need to define what much or somewhat or less or more means prior to completing the goal attainment scale, because if you don't have operational definitions of what those words mean, then this tool would be invalidated. The other nice thing about the goal attainment scale that you can't get just through writing SMART goals or in our traditional way is that this tool allows you to weight goals. So you can weight an importance of a goal, and you can make one goal more important than another, and this tool will take that into consideration when calculating their final score. Another nice aspect to using the goal attainment scale is that this scale really encourages collaboration among the therapist, the patient, and the family when applicable, as well as communication. The patient is always involved in assisting in setting these outcomes, and we know that the evidence suggests that a patient's more likely to achieve their goals if they have a vested interest in the behavior or their salience in that behavior, and the goal attainment scale allows for that. Additionally, using a goal attainment scale is a better fit as it relates to it being more sensitive for that particular patient or responsive to change, because it's specific to that patient. So it's really going to do a good job of capturing small improvements in a patient's progress, and you're more likely to avoid those floor and ceiling effects. Next, we'll quickly review the steps as to how you would go about using the goal attainment scale. The first area that you would need to do is to identify the goals or the main problems that you want to work towards in therapy. And again, that's going to be an agreed upon priority goal area between you and the patient and the family. So you're going to identify the goals, and you're going to write those goals in using the SMART format that we talked about a bit earlier in the lecture. So again, that SMART principle that they should be specific, measurable, attainable, realistic, and timely. Once you've identified the goals, you will go on to weight the goals. So thinking about weight being a function of importance times difficulty, you will use a 4-point scale for that, and you don't need to know these details necessarily, but you will weight the goal and make some goals more important than others. And again, that's a collaborative effort between the patient and the therapist. You have to then go and define the expected outcome. So what do you want to have happen? That is usually set at that level 0 of that 5-point scale. The baseline score is usually what you end up defining as that -1. So we want the goal to be 0. That's the expected level of improvement. So their typical performance, what they're currently doing, is usually going to be set at that -1. The other nice thing about being able to define those expected outcomes, what does it mean to be somewhat less or somewhat more or much less or much more? The fact that you as the therapist get to define that also is nice for the patient, because if the patient has expectations that are really high and that you think perhaps might not be that realistic given that time parameter, you can still include what the patient wants in the goal by setting that at that +2 level. So it's nice in that respect, because everybody at the table feels as though their their hopes and their dreams and their wishes are accounted for using the goal attainment scale. And then getting to the scoring, there is a formula that is used to be able to get a score, and there's a table that's published. We're not going to take it that far in this course, but we want you to understand the purpose of the goal attainment scale and kind of these basic premises and what it offers for both the therapist and the patient. This last slide on the goal attainment scaling shows a sample score sheet, and you can see from this score sheet the different domains and areas that we talked about. So you have your patient stated goal, and then the therapist writes the goal in the SMART format. The importance or the importance is listed there, and the difficulty, that's what gives you your weight value by multiplying those two. You have your baseline score, and then whether or not it was achieved and to what extent. So much better, a little better, or as expected. So this is just one sample. There are a few different versions of sample score sheets for the goal attainment scale, but you can see the areas that we talked about in the previous couple of slides. Again, you are not going to be responsible for actually completing this goal attainment scale, but you should know the basic constructs of the goal attainment scale and how the scoring works, and be able to relatively define what those numbers would mean. These next few slides will be a discussion of terminology as it relates to both the previous guide to PT practice from 2003 and then our more current online version from 2014 and some of the differences that have occurred. In 2003, the Guide to PT Practice was defining discharge as the process of ending physical therapy services that had been provided during one episode of care. And that would happen when the patient successfully completed the established goals and outcomes for that particular episode of care. So patient did well, met all their outcomes, and the therapist evaluated that and then subsequently discharged that episode of care or ended it. The next term that we'll discuss is the term discontinuation. Recall that this is still in line with the previous guide to PT practice from 2003. Discontinuation differs from discharge because in discontinuation, the patient stops a specific episode of care for physical therapy despite the fact that they have not met all of their goals and outcomes. So this could happen for a variety of different reasons. It could relate to the fact that the patient has moved and is no longer in a proximity to receive that particular episode of care from that physical therapist. Their insurance could have run out. They may have another pressing medical issue that supersedes their need to receive physical therapy, perhaps cancer treatment, or if you were the outpatient therapist, perhaps they fell and fractured their hip, or they're in the ICU and there's some sort of medical concern that supersedes the need for that particular episode of care with you. The individual responsible for bringing them could have had a change in employment or access to transportation, and they can no longer get there. Perhaps the patient is no-showing, and there's a policy in that organization that requires that therapist to discontinue those services. So there's many reasons why that might occur, despite the fact that the patient hasn't achieved all of their goals and outcomes that had been established for that episode of care. The newest version of the Guide to PT Practice, the online version, was published in 2014. With that publication, there were some terminology changes that we did discuss last semester in our podcasted lecture. So as we just reviewed, we talked about the definition of discharge and we talked about the definition of discontinuation from the 2003 guide. The 2014 guide takes those two terms of discharge and discontinuation and essentially combines those terms into the term conclusion or conclusion of care. We'll go on to define that in the next slide. By definition, per the Guide to PT Practice in 2014, conclusion of care happens when the goals or outcomes for that patient have been met, when the patient is no longer progressing towards those goals and outcomes, when the patient chooses to stop therapy, or when the therapist determines that the patient will no longer benefit. So essentially, any possible scenario, whether the patient has met or has not met their outcomes, is now encapsulated in the term conclusion or conclusion of care. We still hear clinicians refer to discharge as the strategy to end an episode of care, but really, according to the APTA, the current terminology that any clinician should be using to refer to ending a particular episode of care for any reason is conclusion. Since the term conclusion of care encompasses really any and all scenarios, whether the patient met their expected outcomes or they did not, there can be numerous reasons why this may have happened, and we've talked about most of these on previous slides. The only areas it looks like we haven't spoken to specifically is if the patient just opts out of therapy, so that will happen at times. The patient isn't seeing the perceived benefit, or there's other aspects of his or her life that they feel requires more management and they decline to continue with services for one reason or another. The other aspect is related to plateauing. So when a physical therapist feels the patient is plateauing after intervention for a specified period of time and is not making any more progress towards those outcomes, that therapist may choose to conclude that episode of care for those reasons. Regardless of the reason, one of the key take-homes here is that the documentation of the reason needs to be really clear in your conclusionary note, or what we would call a discharge summary. You need to be able to specify exactly why the episode of care is ending, so that at no point can any one entity come back and accuse the therapist of patient abandonment or just not being clear on what the status of that patient was. So really important to make sure that those reasons for concluding the care or ending that episode of care are clearly defined within that conclusion note. Now that we've discussed the operational definitions of the terms discharge, discontinuation, and conclusion of care, we're going to talk about how you logistically go through the process of concluding an episode of care. First and foremost, if you're thinking about whether or not a patient has made enough functional progress to achieve their outcomes, you have to test the outcomes that you established for that patient within that episode of care. You did this last semester in clinical exposure, and you'll be going through this process again this year with your patient in clinical exposure. So you will compare their behaviors and their abilities on their outcomes from when you first started seeing them, and then you'll retest those outcomes and any other tests and measures that you find pertinent in that link to function, and you'll compare and contrast their current abilities as it relates to their baseline and where you expect them to be or what you set that outcome for. You'll do that comparison and summarize your findings into documentation, which would then serve as your conclusion note. In instances where the patient hasn't achieved their goals and outcomes, and you're concluding that episode of care for other reasons, which we've already previously discussed, you just want to, again, make sure that those rationales are clearly documented in your conclusion of care note. As you go to conclude an episode of care for your patient, either in clinical exposure or while you're out on your clinical internships, you will need to make sure that your documentation is thorough but also concise. This slide represents a list of bulleted items for areas that you would want to make sure that you cover within your conclusion of care note. You'd like your note to be thorough yet also concise. You'll see the asterisks here. Those indicate areas that you really want to make sure that you discuss and that are very important within your conclusion note. So if we just take a look here through this list, we just got done talking about performing tests and measures or reassessing those patients' outcomes. You want to provide a summary of those updated tests and measures so that you can show the patient progressing through that, or perhaps you're attempting to show that they've plateaued and that is your rationale for concluding that episode of care. But you want to provide a summary of those updated tests and measures and provide that compare and contrast. You also want to make sure to provide a summary of the treatment intervention that the patient received while under your care. So this will be helpful for insurance companies and also in any future episode of cares to know what either has worked or what was tried and hasn't worked. And really, this is a summary. You're not going to provide every single exercise that you had the patient do, but really a summary of what you worked towards during therapy. You want to make sure that you provide information pertaining to any sort of home exercise program or any sort of instruction that you provided to the patient. If you don't document any sort of instruction, then it is like it didn't happen. So anything that you discuss with the patient relating to their care, you want to make sure that you include that in your documentation. If you did develop a home exercise program, it would be a good idea to attach that program to your conclusion of care note. Discussing and writing down any sort of recommendations or referrals for assisted technology, referrals to other specialists, anything of that nature, you want to make sure that you document that so individuals know that you're aware that there is potentially a concern or you're seeking additional evaluation from other healthcare professionals and that it wasn't something that you overlooked. So you want to make sure that you include that as well. From a logistics perspective, you'll talk about the number of times you've seen the patient over that time period in which they were seen, and also the times that you did not see the patient and the reasons for those. That's really going to speak to How much of the needed program did they complete? Was the patient non-compliant? That just helps support your rationale for ending services if indeed they did not meet their expected goals and outcomes. And then any additional recommendations for follow-up. Given that the patient population we've been talking about is adults with adult neuromuscular onset disorders, it's quite possible that a patient that you previously concluded their care may return for a new episode of care as challenges change and as impairments persist or potentially get worse. You may also start a new episode of care for a patient you've never seen before but has received physical therapy elsewhere. So many times patients will have multiple episodes of care. You may find that your patients in clinical exposure are also concurrently receiving a different episode of care with another physical therapist. That's also common for adults with neuromuscular disorders. This slide lists a variety of factors that might necessitate a new episode of care, and it's really the converse of the slide that we talked about earlier about why a patient may choose to end an episode of care. So if we just take a look through this list, we can see that patients with neuromuscular challenges might have changes in their physical status. So perhaps this is a patient with MS who is having a flare-up, or a patient with Parkinson's who has had a fall and now has some additional mobility needs. They could have a change in their socioeconomic status. Perhaps they're newly employed and they have different health insurance and can now begin that process again. So it could be some type of change within the patient themselves, which now necessitates a new episode of care. It could be a change in their caregiver status. Perhaps now their caregiver is accessible and able to take them to therapy, whereas before they weren't. Perhaps they're in a new environment. They've moved to a location that now they can access services when before they could not. Or maybe within that environment that they're in, a new job, a new home, the demands of what they need to be able to do to be mobile and to be efficient and effective in those environments has changed. So perhaps a patient who didn't have stairs before now does have stairs, or their new job requires some sort of task demand that they are currently unable to do or are struggling with. So there could be issues surrounding that. And then we've kind of talked about this last bullet already, accessibility and availability of resources. That could really change based on the environment changing, the insurance company changing, the caregiver being available. So that last bullet kind of feeds into the areas that we've previously discussed. Just a few more terminology pieces before we finish up this lecture. The episode of care that we've been talking about, the APTA Guide to PT Practice defines that as an unbroken sequence of therapeutic interventions. So the patient begins an episode of care, and that is an unbroken episode that's not interrupted by any other surgeries or transfers out of that outpatient clinic or out of the hospital clinic that they're at, but it's essentially an unbroken sequence of physical therapy. You may also elect to place a patient on more of a maintenance service or a consultation basis where the patient might occasionally come in, you reassess them in some limited capacity, perhaps you're updating their home exercise program. So the APTA does define an episode of physical therapy maintenance as some occasional physical therapy related sessions that's really usually educational in nature. An episode of physical therapy prevention is somewhat similar to maintenance in that it's more of an occasional visit or a check-in or a consultation, but you're really trying to prevent impairments from occurring. So it's more of that primary prevention strategy that we'll talk much more about in the fall semester of your third year in the curriculum here. That concludes this lecture. Please reach out through email or office hours or seminar if you have specific questions about the content that was contained in this lecture. You'll be using this information moving forward into your clinical exposure coursework as you think about setting outcomes for those patients after their examination evaluation is complete, and also towards the end of the semester as you think about concluding that patient's episode of care.